Chapter 22, Obstructive Pulmonary Disorders. So in this chapter, we'll talk about conditions like asthma, bronchitis, emphysema, bronchiectasis, and cystic fibrosis. So a little bit about our airways. So our autonomic nervous system is going to control the diameter of our airways, and as a result, the resistance to airflow. So if we were to bronchoconstrict, resistance increases and airflow decreases. When we bronchodilate, resistance decreases and airflow increases. So it's all about whether or not we're contracting the smooth muscles around our bronchioles. Now, the autonomic nervous system includes the parasympathetic and sympathetic branches. So the parasympathetic nervous system will cause bronchoconstriction, and it's going to occur via vagus nerve innervation and through the activation of our cholinergic receptors, specifically the muscarinic receptors. The sympathetic nervous system releases norepinephrine and will bind to the beta-2 adrenergic receptors, which will result in bronchodilation. Now at rest, because we are resting and digesting, we are under a slight vagal-mediated bronchoconstrictor tone, since we are in a parasympathetic-dominated state. So let's take a look at different obstructive pulmonary disorders. Now these are going to manifest by an increased resistance to airflow. So essentially, the increased resistance to airflow is going to make it difficult to exhale air. There are different classifications. So the obstruction can occur from a condition in the wall of the lumen, and asthma and bronchitis are examples of those. We can have obstruction resulting from increasing pressure around the outside of the airway lumen, and emphysema would be an example of that. And then there can be an obstruction of the airway lumen itself, and we see that in bronchiectasis and cystic fibrosis. So let's start with asthma. So the etiology of asthma is that we have an airway obstruction that is reversible, although not completely in some patients. You're going to see inflammation associated with asthma, and as well as increased airway responsiveness to different stimuli. So think of an allergy. About 5 to 12% of the U.S. population suffers from asthma, and it's also the most common chronic disease in children. And high-risk populations include African Americans, inner city dwellers, as well as children who were premature or had very low birth weight. There are other predisposing factors, like your genes play a role, having a history of hay fevers, eczema, positive skin test to allergens, and so notice all of these are really associated with allergies and the immune system. We have different categories of asthma. We have extrinsic and intrinsic. So let's start off by discussing extrinsic asthma. So in extrinsic asthma, this is going to be the one that's mediated by allergy or our allergic response. So about a third to half of the cases of asthma are extrinsic. Because it's related to allergy, if you recall from our immune chapters, it's going to be IgE mediated. And skin tests can help identify what we're allergic to. So our allergies can include things like tree, grass pollen, mold, etc. And so what's the mechanism of action? Well, it's similar to what we learned about in terms of an allergy. So IgEs are produced in response to whatever allergen we're exposed to. They're going to bind to, those antibodies are going to bind to the mast cells, and that's going to cause the release of inflammatory chemicals when we are exposed to the allergen. So we're going to see the release of histamine, leukotrienes, prostaglandins, bradykinin, etc. And if you recall, we talked about how important histamine is in this response. So we'll see things like increased vascular permeability, we'll see vasodilation, we'll see bronchoconstriction, and this is where the asthma comes in. Epithelial damage will also occur, and we can also see smooth muscle and mucus gland hypertrophy, which can increase mucus secretion into the lumen of our airways as well. So here we have an image of a normal airway, and then here is one that is suffered from asthma. So we can see the lumen is much more narrow, so there's increased resistance, decreased airflow. Here we see thick excess mucus being secreted, and we can see the increase in mucus glands and just the overall inflammation that has occurred here. We then have intrinsic asthma. So this one is not associated with allergies. So no antibodies are produced here. So no IgEs are involved. Instead, it can be caused by things like exercise, stress, aspirin, exposure to pulmonary irritants like cigarette smoke, and cleaning agents. These irritants cause an asthmatic response. So people become hypersensitive and the smooth muscles essentially constrict. And that constriction is what leads to asthma. So we have increased airway resistance. We can also see increased mucus production here as well. So whether you have intrinsic or extrinsic, these are the common signs and symptoms. So we'll see wheezing, feeling of tightness in the chest, dyspnea, so difficulty breathing and shortness of breath. We have cough. It could be dry or productive. So productive cough would be all the mucus secretion. So we also see increased sputum production. So that's a mixture of mucus and saliva. If we have a severe asthma attack, we'll start to use our accessory muscles to breathe. And so that eventually becomes very exhausting because you're not breathing just with your diaphragm and your intercostals. You're really recruiting your sternocleidomastoids and your scalenes to really help you breathe. You can also see intercostal retractions where the intercostal muscles start to pull in sharply, and again, it makes it difficult to breathe. You'll have distant breath sounds with inspiration, orthopnea, which is shortness of breath when you're lying flat on your back, and feelings of agitation, tachycardia, rapid breathing. So notice this is an emergency. So a lot of these we see are response of the sympathetic nervous system kicking in. So what can we do to treat asthma? So one of the main things we want to do is avoid your trigger. So if you know you're allergic to certain things, that's what you want to avoid. Control your environment, remove allergens, use air purifiers. You can also try desensitization, which is essentially immunotherapy. And then finally, we can have medication. So oxygen therapy, that would be low dose oxygen. Beta-2 agonists, so that has to do with the adrenergic receptors, so the sympathetic nervous system, which we know bronchodilates. Corticosteroids to deal with the immune response, leukotriene modifiers. Again, those are some of the chemicals released by our mast cells, and there we go, mast cell inhibitors. So this is just a figure that kind of shows how the mast cell is involved in our asthma. Okay, so the next condition I want to talk about is bronchitis. So chronic bronchitis is actually a form of COPD, chronic obstructive pulmonary disorder. Under COPD, we have chronic bronchitis as well as emphysema. So we'll start with the bronchitis. This is a persistent narrowing of the airway due to chronic inflammation, scarring, excessive mucus production. So we really see hyper secretion of mucus, and you can see that here in this yellow part of the image here. Obviously, that's going to, again, narrow airway, increase resistance, make it difficult to breathe. Chronic or recurrent productive cough that lasts more than 3 months a year for 2 or more years would constitute having chronic bronchitis. So just having it for a month is not going to be considered chronic, but it lasts 3 years for 2 or more consecutive years. The resultant airway damage, unfortunately, is not reversible. And it's also known as type B COPD, or they are also known as blue bloaters. And they're known as blue bloaters because they are going to be cyanotic, so they'll turn blue. And the patient typically is overweight, and there's a 1-to-2 male to female ratio. And it's more common in those over the age of 30 to 40, and it's also commonly associated with our other COPD, which is emphysema. So what causes chronic bronchitis? So 90% of cases can be associated with cigarette smoke. Also, having repeated airway infections can damage the airways and cause bronchitis. And genes can predispose you, as well as inhaling physical or chemical irritants that can, again, really affect our airways. The pathogenesis is that we'll see chronic inflammation, swelling, of the bronchial mucosa that results in scarring, and we'll also see hyperplasia of mucus glands, which are going to secrete our mucus, or goblet cells, which also secrete our mucus. We have increased bronchial wall thickening as these mucus cells increase, and we can also see pulmonary hypertension, which is high blood pressure in our pulmonary circuit. So what will it manifest as? So you'll start to see shortness of breath, excessive sputum and productive cough, and that would be, again, because of all the mucus that's being created. You'll see chronic cough that's typically more severe in the mornings, and evidence of excessive body fluid, so edema and hypervolemia. Also, you'll see cyanosis. This is why people who have chronic bronchitis are known as blue bloaters, because you'll start to see that blue tinge in the skin. And because of the cyanosis, because of the low oxygen, the hypoxemia, that causes our body to respond to low oxygen. And we learned that in the anemia lecture that when there's low oxygen, our kidneys are going to release erythropoietin to stimulate erythropoiesis. So as a compensatory mechanism, we would increase red blood cell production. And so that leads to polycythemia. Also, because we have alveolar hypoxia, so low oxygen, we'll see a lot of vasoconstriction happening. And that's why we see the pulmonary hypertension. So if certain alveoli are not getting oxygen, then the blood vessels that supply those alveoli will vasoconstrict. And by doing that, we're going to redirect blood to the alveoli that are still getting oxygen. And again, we know when we vasoconstrict, we raise blood pressure. Because the vasoconstriction is happening to the blood vessels that supply our alveoli, the rise in blood pressure would be in our pulmonary circuit. So that's why we see the pulmonary hypertension. And because we know that the right ventricle is the chamber of the heart that sends blood to the lungs, the high blood pressure in the pulmonary circuit will result in our right ventricle starting to have to work harder to supply blood to the lungs. And so the right ventricle will start to remodel in response to that, and we will see right ventricular hypertrophy. And so this change in the right side of the heart due to an issue in the lungs is known as cor pulmonale. And so when we make our right side work harder and it starts to hypertrophy and we're constantly making it work harder and harder, eventually we can have right-sided heart failure. Now, how do we treat chronic bronchitis? Well, remove the etiologic factors. So we said 90% of cases is related to cigarette smoke, so stop smoking. We can also provide bronchodilator therapy, try to remove the secretions, thin it out, cough it out. We can prevent respiratory muscle fatigue by doing certain exercises to breathe more efficiently, essentially, and then provide low-dose supplemental oxygen. Okay, so let's move on to the other COPD, which is emphysema. So this results from destruction of alveoli as well as small airways. And again, it primarily occurs in smokers, and it's often associated with chronic bronchitis. Now, those who had chronic bronchitis, we said they were known as the type B COPD and known as blue bloaters. People of emphysema are referred to as the type A COPD, and they are also known as pink puffers. And they're going to be pink because they're really going to work hard to maintain oxygenation. So by working harder, they get that pink flushed look. So what causes it? So smoking more than 70 packs per year. And 70 packs is actually not a lot for someone who is a smoker. Air pollution, certain occupations like mining, welding, asbestos. And again, that would be being exposed to chemicals that get into our airways and damage it. And then there's an issue with alpha-1 antitrypsin, and I'll talk about that here. So if we take a look at the pathogenesis of emphysema, we have alveolar destruction. So our alveoli are getting destroyed because we have immune cells releasing proteolytic enzymes. Now, why are the immune cells doing that? So let's take a look. We said smoking is one of the major causes. When we smoke and bring in irritants into the alveoli, our immune cells are going to respond to that. And they're going to release chemicals like elastase, like trypsin, that are going to try to destroy these chemicals. But when they do that, they also destroy our alveolar tissue as well. Now, normally, we will also secrete something called alpha-1 antitrypsin. And the alpha-1 antitrypsin is going to protect us from these proteolytic enzymes so that we don't damage our own tissue, like the alveoli itself. Now, what smoking does is not only does it attract more immune cells to release more of these proteolytic enzymes, it also inhibits the action of alpha-1 antitrypsin. So not only are you bringing in more destroyers by smoking, smoking is also reducing the activity of the protectors. And as a result, you get destruction of alveoli and loss of alveolar tissue, elastic tissue in the lungs, and so it makes it difficult to breathe. So emphysema causes two major problems with breathing. So number one is all of that destruction of alveoli results in a decrease in surface area for gas exchange. The whole purpose of having so many alveoli, and the reason you're able to get that is because our lungs branch so many times, is because it increases surface area. And the greater the surface area, the greater the rate of gas exchange. But when we destroy alveoli, our surface area gets much smaller. And so the rate of gas exchange will reduce. So we don't get as much oxygen in and as much CO2 out, essentially. The other issue is we're going to start to see airway collapse, and that's going to be due to loss of radial traction. So as we damage our airways, when we expire, because we lose radial traction, our airways will actually collapse in the midst of expiring. And so the airways, instead of staying open so that we can get all of the air out, it collapses, and so that old air gets trapped in our airway, so in our lungs, and so we start to see hyperinflation of our alveoli, but it's hyperinflated with old stale air that's low in oxygen and high in CO2. And so manifestations include dyspnea, difficulty breathing, weight loss, and then again, you'll really need to use your accessory muscles to help you breathe. You'll also see a low, flat diaphragm and a barrel chest, and that's associated with all of that old, stale air getting trapped in the lungs, pushing our diaphragm down, making our chest wall kind of puff out, creating that barrel chest look. You'll also see a lot of people do pursed lip breathing, and this is shown here. This is a good example where you breathe through pursed lips, and by doing that, you actually can keep your airways open longer so that you can get more of the air out before it collapses. So it kind of keeps the pressure gradient in such a way that you can keep the airways open. Also, leaning forward to breathe has been shown to help people with emphysema to, again, get all of the air out. And again, you need to get the old air out so that in the next breath, you can bring in fresh air. You'll see a cough, and then cyanosis can occur, but it's really not until the very late stages, which is why they tend to look pink because they're really working hard to breathe, as opposed to blue that might happen later on. So how do you treat emphysema? It's going to be very similar to how you would treat chronic bronchitis. So stop smoking to prevent progression of the disease. Unfortunately, whatever damage you have is irreversible. And then low-dose oxygen therapy can try to help improve quality of life. So to review the pink puffers and blue bloaters. So the pink puffers were people with emphysema. So why are they pink? Because they are working very hard to try to sustain oxygen levels. So they can work hard enough. And by doing that, you know how you get flushed when you are exercising. But good news is by doing that, you can maintain blood oxygen levels near normal. But obviously, the more severe the case, that would not be, the more severe the case of emphysema, that may not actually be able to be sustained. You'll see shortness of breath, again, increased effort to breathe, use of accessory muscles, and that pursed lip breathing. Blue bloaters are usually people with the bronchitis, and they cannot increase their respiration enough to maintain oxygen levels, which is why they are cyanotic. You'll also see polycythemia, and we talked about how the cyanosis is related to that. And then chlorpalminol, now that's listed here, but really any issue with the lungs where you have low oxygenation and you have hypertension occurring, you will see the right ventricle remodel in response to that. So you can see chlorpalminol not just in chronic bronchitis, but in other issues as well. But again, that chlorpalminol is where you have remodeling in the right ventricle due to an issue in the lungs. Okay, the next airway issue is bronchiectasis. So bronchiectasis is like having an aneurysm, but instead of in your blood vessels, it's in your airway. So if you recall, an aneurysm is like a dilation. So that's the same thing here. So it's a dilation, but instead of in your airways, it's in your bronchioles. And you can kind of see that little big bubble. Now, the dilations that occur, you're going to start to see old mucus getting stuck here, and so there's likelihood of infections occurring. You'll have really foul smelling sputum, and recurrent infections can damage the bronchial wall, leading to that dilation, and as well as recurrent inflammation damaging the wall. And another thing that happens is you also damage the cilia, and so cilia normally helps remove mucus from the airway, but because that's damaged, the mucus kind of sticks around, and that's why you have this old mucus really stuck in this area. You'll see chronic productive cough, and you can also see digital clubbing. Now, digital clubbing, again, is I'm mentioning it here with bronchiectasis, but it can happen in any condition where you have really low oxygen, and I'll talk about what that is in the next slide. So how do we treat bronchiectasis? Well, one of the things that we're going to focus on is antibiotic therapy because of the infections that can occur in this pocket of mucus, as well as to try to remove the excess secretions. So what is digital clubbing? Now, this is not something that happens often. It does occur infrequently, but it is caused by prolonged decreased oxygenation. So again, we're seeing it as an example here, but any issue where we have low oxygen, we can see this. Now, the severity of the clubbing will correlate with the severity of the oxygenation issue. But essentially, if you put your index fingers together like this, a normal finger or two index fingers coming together, you should see a little diamond in between if you hold it up to like the light. I don't know if you can see that here. But with digital clubbing, you got a change in the nail bed. And so when you put your finger together, it's completely flush, if you can see that. Okay, so go ahead and take a look and see whether or not you have any digital clubbing. All right, next, I think this is the last one we're going to discuss, and that is cystic fibrosis. So cystic fibrosis is an autosomal recessive disorder. So again, you need both alleles, diseased alleles, to express this disease. And it's a disorder of the chloride and water transport proteins. And so what it does is it causes dehydration, and it causes your mucus to get very, very thick. Now, mucus is found in different parts of the body. So you don't only see issues in the respiratory system, you'll also see issues, for example, in the intestinal tract. It affects about 1 in 2,000 to 3,000 Caucasian births. Now, the thick mucus will obstruct your airways, causing air to trap in the lungs, but it will also obstruct, for example, your pancreatic duct, your biliary duct, and so it can affect your GI tract as well. It can even lead to infertility in males. It can affect the sweat gland. So really anywhere where we have secretions and mucus and fluids being released. Treatment is centered on removal of the secretions and then also to provide the antibiotic therapy so that we don't have infection building up in these thick mucus that's just kind of sticking around. So a client has cystic fibrosis and they're having respiratory problems, but they're also having some GI issues. So they have excessive gas, they have a lot of fat in their feces, they're losing weight, and they don't understand why a respiratory disease is causing these problems. So how do you answer that? Well, we know that cystic fibrosis is going to lead to dehydration and very thick mucus. And that thick mucus doesn't just happen in the respiratory system, it also happens in other areas of the body, including the GI tract. And so the thick mucus in the GI tract is causing these GI issues like fat in the feces, excessive gas as bacteria is trying to eat off of the undigested food and they produce excess gas. Okay, so what are some of the consequences of COPD? So COPD, like we said, decreases your ability to exhale. That's really where we're going to see the issue. And so when you can't exhale, we're going to have stale, old air sticking around in your lungs. So that stale air is going to be low in oxygen. As a result, it leads to hypoxia. The stale air is going to be high in CO2 levels, and so it leads to hypercapnia. So low oxygen, high CO2. So which step in this flowchart will cause the central chemoreceptors to increase respiration? So essentially what we're asking is which gas do your central chemoreceptors kind of pay attention to? And that would be CO2. So your central chemoreceptors really pay attention to CO2 because the more CO2 you have in the body, it really changes your pH. And so it will respond to the hypercapnia, which will cause the peripheral chemoreceptors to increase respiration. So your peripheral chemoreceptors really pay attention to oxygen. So it would respond to the hypoxia. Now, in a client with COPD, exhalation is inefficient and oxygen levels in the lungs start to decrease. Now, if blood goes through the lungs that's filled with the stale air, which we know has low oxygen and high CO2, it won't pick up much oxygen and it might even pick up the CO2. So what will the pulmonary arterioles that feed this area of the lung do? Well, if we know blood is going to go to an area of the lung where it might pick up CO2 and not oxygen, we don't want blood to go there. So our pulmonary arterioles will vasoconstrict. Okay, so we don't want blood to go to that area of the lung, and so we'll vasoconstrict. So again, that's why we have the pulmonary hypertension starting to occur. Which side of the heart will be affected? Again, this goes back to normal blood flow. We know blood from the right side of the heart is what goes to the lungs. So all that constriction in the lungs is going to really impact the right side of the heart. And that impact on the right side of the heart due to issue in the lungs is the cor pulmonale. Okay, so Mr. X's father developed emphysema very early in life. So Mr. X's doctor is having him tested for alpha antitrypsin. This doesn't make sense to Mr. X because he knows that trypsin is a digestive enzyme. How will you explain it to him? Well, he's absolutely right. Trypsin is a digestive enzyme, but it's also released in the lungs. And normally, we have alpha-1 antitrypsin to block the action of trypsin so that we don't damage our own tissues. And so he's looking to see if there's an issue with the antitrypsin that might be causing emphysema. So it says enzymes such as trypsin can also be released by inflammatory cells in response to an irritant such as smoking. If it's released in the lungs, it can damage alveoli unless the alpha antitrypsin is there to stop the process. And we talked about how smoking not only increases proteolytic enzymes, but decreases the activity of the antitrypsin. So Mr. X says what he's really worried about is heart failure because that's what actually killed his father. So he figures, hey, emphysema must not be a very serious disease after all. Could emphysema and heart failure be related? Well, we've talked about this already. When we change the activity of our lungs, especially when we increase blood pressure in the lungs, which side of the heart can be impacted? That would be the right. So yeah, absolutely. We can see right-sided heart failure as an issue if we don't deal with emphysema. So Mr. X remembers vividly that even though his father was so sick and suffering from not being able to get his breath, the nurses wouldn't give him as much oxygen as he needed. So why wouldn't they increase his oxygen? Now this goes to our chemoreceptors. So after years of emphysema, his chemoreceptors are regulating his breathing by measuring O2 rather than CO2. Now keep in mind, our central chemoreceptors sense CO2. And so we really breathe based on CO2. CO2 is really the driving force. But because he had emphysema and his CO2 levels were high, our body kind of got used to the high CO2, and so it's been measuring oxygen as a way to regulate breathing. So if they were to raise his oxygen level too high, his chemosensors will recognize that there's a lot of oxygen, and so it'll essentially tell you to stop breathing or really slow down breathing because it thinks it has enough oxygen, which it does. But the problem is there's a lot of CO2 that we're not getting rid of, and that can cause you to fall into having respiratory acidosis because the more CO2 you have in your body, the more acids in the body. Okay, thank you.